Does your child wet the bed and have ADD symptoms? Do you struggle sleeping? Or do you or your child have really crooked teeth? You probably feel like you or your child is going to die unless you get the problem fixed. Well, maybe not die. Maybe you just feel like it's gonna be really bad. So there is a problem called OSA, obstructive sleep apnea, and it varies in severity. Untreated, it can lead to things like an increased risk in sudden cardiac arrest. That means death. So yes, it can sound bad, and that's probably the worst outcome. Tooth pillow and other devices like the Vivos appliance, Healthy Start, MyoBrace, Sleepo Brace, the ALF appliance, and AGA, and probably more. Can these devices fix a potential problem that will prevent and or cure obstructive sleep apnea and help you avoid things like sudden cardiac arrest? Let's dive deeper. Let's go to the tooth pillow. Let's go to the facts section. What qualifies your doctors to treat my child? Our doctors are qualified dentists. Their dental license are current, and they also carry special training in the field of airway and dental sleep medicine. This includes diplomats from the American Academy of Dental Sleep Medicine and the American Sleep and Breathing Association, among other accolades. Did you know there was such an organization? That seems like a big deal. We should probably see what they have to say about all of this. Novel therapies for preventing, managing, and treating obstructive sleep apnea and snoring in pediatric and adult patients. Before we get into the meat of this wonderful information, the facts, be sure to subscribe to the channel if you haven't already and like this video. All right, so what they decided to do was to evaluate theoretical risk factors, what these airway friendly and other folks hypothesize. All right, so for example, over there on the left, one of the risk factors could be dental and skeletal malocclusion. Dental could just be a lot of crowding. Tethered tissues like frenums. We hear a lot about frenectomies with children that are having trouble with breastfeeding, and it's been argued that they may contribute to sleep or breathing problems. Tongue motor immaturity, right? If your tongue's not in the right spot, it's losing tone, it's not postured correctly, that could also be a potential risk factor that's being evaluated here. Soft palate or adjacent soft tissue anatomy and physiology. Risk factor extraction, that's a big one. We've made other videos about this. Are these things risk factors? So here are the questions we're trying to answer. Based on the available evidence in adult patients, is it appropriate to use, in adults and children, expansion or myofunctional orthodontics to prevent, manage, or cure OSA? All these devices, tooth pillow, MyoBrace, even orthodontic expanders, things like that, are being used to try and spread the jaw, make it wider, right? More room for the teeth, more tongue space, and better relationship of the jaws. Potentially, expansion doesn't do that too much unless you got a crossbite. Buccal or lingual frenum releases to prevent, manage, or cure OSA or snoring. The frenums, the tissue that attach from our lips or underneath our tongue to our tongue, right? Those things would correcting those improve, cure, or prevent OSA. Tongue motor activity, myofunctional therapy to prevent, manage, to cure OSA or snoring. The prevalence of OSA in children ranges from 1% to 5% and tends to peak between the ages of 2 and 8 years old. First of all, 1 to 5% could represent a lot of people, but comparatively speaking, 1 to 5% is not that much. There is a good chance that your child does not have OSA. There's a good chance that you don't have OSA. Of course, pediatric OSA has been associated with a number of craniofacial morphologies, features. Basically, we're just talking about top teeth being way out in front of the bottom teeth like this, right? And usually that can be associated with the lower jaw that is back. Caution must be exercised in assuming that treatment to alter unfavorable craniofacial features will prevent, manage, or cure OSA in children. You shouldn't just like jump right into certain interventions to correct these morphologies thinking that they will prevent, cure, or even manage OSA in children. Word of caution. Adenotonsillectomy is considered the first line therapy for pediatric OSA, typically under the age of 7, because it basically reports or suggests that research has been done to show that around 79% of children with mild to moderate OSA experience normalization. So it's almost 80% after the adenotonsillectomy. Kids with OSA, they go through that 80%. Boom, done. Great therapy. Not fun, I've heard, but very effective. It is noteworthy, however, that in the control group of untreated patients, watchful waiting resulted in spontaneous normalization of the test findings in 46% of children with mild to moderate OSA, suggesting that nearly half of children with mild to moderate OSA will naturally improve without intervention. That's the amazing part about growth. You know, orthodontists, even, we have to be careful, and all the other providers, there is so much good that growth does, natural growth can do. And of course, there's exceptions to the rule, like if the OSA is contributing to a person not growing. But in mild to moderate cases of OSA, that can happen when a child is young, up to 50% may improve naturally by just growing. While up to 28% of healthy children snore, habitual snoring is prevalent in 3 to 12% of the pediatric population. So just to emphasize, 28% of healthy children snore, right? So snoring in and of itself is not indicative of a medical condition. Asymptomatic snoring in children is typically not considered to require medical intervention and may be transitioned during growth and development or a short-term issue not requiring intervention. Boom, there you go. First, we're gonna talk about expansion. This is a big one because everybody is trying to expand everybody right now, especially with these devices, even in adults. It is important to differentiate how expansion in adult populations differs from expansion used in pediatric patients, okay? So watch out for those people that are trying to tell you that you can expand as an adult. While the intent of the therapy is to expand the mid-palatal suture, this is more difficult to accomplish in adults because the mid-palatal suture and adjacent circummaxillary sutures are more resistant to expansion without surgical assistance or device enhancement. Mid-palatal suture, right, with young kids, haven't gone through puberty yet, very predictable to try and get the actual jawbone right here to split right down the middle. But as we get older, this suture and all of our other facial sutures, because we got a bunch of bones that are all connected together, they become more resistant to that expansion unless you have a surgically assisted expansion technique or you have a device enhancement like using screws. Even if you use screws for adults, sometimes you still cut surgically assist so that you can split it apart. As a result, adults exposed to non-surgical arch expansion are at increased risk for less stable tooth tipping, increased root resorption, and cortical bone damage. When people are talking about like, we need to spread your bone out. More than likely, if you're talking about an adult, you're just saying that these teeth right here and right here, instead of being narrow, they're just gonna tip out like this. So you're not really changing the bone at the suture. Unlikely. Adults don't expand unless you have those enhancements or surgically assisted. You can make your teeth wider, but not necessarily your bones. Myofunctional therapy for tongue motor immaturity. Conceptually, myofunctional therapy, MFT, is primarily focused on improving speech and swallowing to enhance oral facial growth, right? That's excellent. It is evolved to include breathing exercises and orthopedic devices. The intervention uses a combination of isometric and isotonic oropharyngeal exercises with the patient working on tasks such as speaking, breathing, blowing, sucking, and chewing through recruitment of the oropharyngeal musculature. Wonderful things. Muscular endurance exercises aim to improve the tone, tension, and mobility of oropharyngeal muscles and soft tissues, which may, hypothetically, reduce airway collapse during sleep, because that's what's been reported to be the main cause of airway obstruction. When we sleep, we lose tone and our airway collapses. You can have people that have narrow anatomical airways but not have obstructive sleep apnea because their tone maintains better while they sleep, while you have individuals with larger airways potentially, and then they collapse while we sleep because they lack the tone. There appear to be few, if any, common approaches between professionals, and therefore it is increasingly difficult to draw solid conclusions. That is very interesting because if we don't have a consensus or an approach that's been repeatable to improve certain conditions, then it becomes hard to test and provide solid conclusions. This is the table right here that I think is important. So they did all these reviews of the data, and you can see here, they gave different categories. Appropriate, these different things, right? These different interventions were appropriate to treat, cure, prevent, or manage OSA. Uncertain or insufficient. Appropriate would be, very good. Uncertain is like kind of in between. We have people on both sides. Or insufficient, majority agreed that, hey, there's not enough evidence to support this claim right now, and we don't feel good about it. None of the therapies examined by the panel were considered appropriate. What does that mean? It means that they didn't have enough evidence. Further research is encouraged to clarify the utility of such therapies. There are some categories here, right, where it's still uncertain, meaning that potentially the risks of the treatment aren't so much that the potential benefits could still be worth trying. There are lots of them that are insufficient evidence. The data is just not there to support claims that providers may be making about how these devices, treatment, procedures can cure, prevent, or manage obstructive sleep apnea. Do childhood tooth extractions lead to OSA in children? No. Do childhood or adulthood tooth extractions lead to OSA in adults? No. So for those of you who are considering getting extractions, right, you still want to be considerate. Talk with your provider. If you already have obstructive sleep apnea, you might want to talk about that. But as far as getting extractions that lead to OSA, the evidence is not there. Based on current available data, what are the take-homes? The conclusions from this panel of American Academy of Dental Sleep Medicine experts. None of the interventions that we've talked about, all those devices, tooth pillow, Vivos, AGA, the removing tissue, the frenums under the tongue, are considered appropriate, meaning that there's not enough data to suggest that any one of those individually as a monotherapy can be used to cure, manage, or prevent OSA in children or adults. You better be careful if you're an adult, you're doing some of these procedures, trying to grow the jawbones, the data is just not there. In fact, the current data that we have suggests that you can't do that, and you could be putting yourself at risk for those unfortunate circumstances. There are plenty of potential adverse effects of doing those procedures, and like I said, the data is just not there. The science is not there to support its use. Myofunctional therapy should be guided by clarification of minimum educational qualifications and standardized protocols underpinned by high quality evidence. So basically it's saying, yes, it's good to consider myofunctional therapy, those things that can help with swallowing, speaking, maybe even proper tongue posture, and good for oral facial development, but, and are those that are training you, are they trained? What kind of training do they have? What kind of protocols are there? And are these tested? So what should you do if your kid is wetting the bed, obviously at an inappropriate age, has symptoms of ADD, not performing well during the day or at school, has super crooked teeth, snores, or is not growing well? Same questions for the adult. Physician, maybe sleep physician, ENT, orthodontist, myofunctional specialist, speech pathologist, right? There are some key important individuals who understand this area of craniofacial development that can help you get the most accurate information related to your particular situation. Not that you can't consider these alternative options from your airway-friendly provider. Whatever you do, based on the current evidence, don't let them tell you that these interventions can cure, manage, or even prevent OSA in your child or as an adult. And don't let them convince you that you won't need, as a result of these things, the good old traditional expander and braces, tried and true, through and through, to help you get straighter teeth, good bite, and a flowing airway. That's all I've got. Just a little PFO so you know where you're going. Packard out.